Hello, everyone. I'm JC with the Peak program. This is a re-recording. I was unable to record the original presentation. On the original presentation, I had Melissa Miller, who is a registered nurse at the Wheatlands Healthcare Center in Kingman, Kansas, present on the risk topic, but I will be presenting for the re-recording. So the outcomes, or for today's agenda, we're going to review the peak outcomes. We're going to talk about criteria when we're developing a risk training. We're going to discuss what we're looking at for risk when we are doing evaluations. And then I will present Melissa Miller's risk training that she does for the Wheatlands. And then when we're all done on the original presentation, I was on the call until 1:30 to answer questions about the presentation and just general peak questions. So for the required outcome, the home is to provide formal training to all team members on how to support resident decisions, including those that could be considered risky. The training must include the position of the organization as it relates to decision making when the choice of the resident might not be in agreement with the policy. It may pose a risk to the resident or does not agree with the caregiver's personal value set. This outcome will be changing to formal training on how to respond when a resident makes a risky decision and staff are able to respond. So the main thing is that staff are getting formal training to respond to resident decisions. So I think that we would all likely agree that from time to time we make decisions that might not always be in our best interest. Sometimes we overeat, we skip exercise or don't get enough sleep. Sometimes we don't always follow our medical providers' recommendations. Person-centered care providers understand that risk is a very normal part of life, and people who live in nursing homes should continue to enjoy the right to make decisions for themselves. So I've included the link to our document. It's a guide for developing risk training. Direct caregivers are often put in a very difficult position by the conflicting responsibility they have to support resident decisions, while at the same time keeping residents as safe and healthy as possible. Homes are required to conduct formal training on how to support residents when they make a decision that might not be in their best interest. We call this a risky decision. A one-size-fits-all training is not possible for this subject. Homes must look at their own practices and expectations related to risk and build a training around that. The training should be specific to your home. There are some subjects that should be included in your training, and that is when we want to refer to the guide for developing risk training. It will provide assistance in developing that. So you want to get your team together and try to clarify your position on risk. What do you expect of your staff? How do you want your team to respond when a resident makes a risky decision? What kinds of situations do you want the nurse to be directly involved in? What kind of situations do you just want the team to tell the nurse about later? As a team, talk through the possible situations and think how you want your team members to respond. You want to, 1, teach your team how to respond on an individual to an individual making a risky decision. 2, we want to consider the severity of the risk to self and others as you decide what your expectations are. 3, determine exactly why a person is choosing not to follow a physician order while they are directing their own life. 4, talk about available alternatives and staff approaches to mitigate risk. 5, we are required to educate elders about the consequences of their decisions. 6, consider where and how you want these things documented. 7, person-centered care plans should address risk. And 8, encourage team members to make decisions on an individual basis. So when we're in homes or meeting virtually for evaluations, here are some of the things we're going to be looking for. The home provides formal training to all employees upon hire and again annually. So we want at least 90% of all full-time and part-time staff who are on the schedule every week to be trained. Seasonal and PRN staff are optional, but it would be best practice to get them trained on this. Evidence includes a copy of the risk training outline used by the home, records of attendance maintained for the risk training. The home describes how they plan to keep new and current employees trained. So now in the original presentation, I turned it over to Melissa Miller. Like I said before, she's an RN at the Wheatlands Healthcare Center in Kingman. She's been there for almost 10 years and she started as a CNA and worked her way up into nursing leadership. The Wheatlands are a level 4 home in the PEAK program, and we'll start her presentation. So the Wheatlands Healthcare Center believes in a person-centered model of care that supports each elder's individuality, independence, dignity, and privacy. The model assumes elders, along with the guidance of their family, physician, or others of their choosing, have a freedom to decide regarding many aspects of care and services they receive, as well as maintain some control over the level of risk accompanying these decisions. Our duty is to allow this freedom while following all regulations and understanding it's their right. In long-term care, there's a dynamic balance between the resident rights and the duty to protect those under our care. When a resident's decisions are in accordance with the family healthcare providers or societal norms, then the issue of decision-making capacity may be less of a challenge. The risks of decisions made are likely to be low and conflict is minimal. Greater challenges arise when there is a closeness of resident incompetence or impaired capacity, and a conflict between the resident's wishes and societal norms, medical advice, or family opinions. In these circumstances, clinicians are called upon to answer the question, can a resident make his or her own decision? Competence is a legal term determined by the courts. All individuals are presumed competent and able to fully exercise their rights as citizens, even if they reside in a nursing home or have a diagnosis such as dementia, unless determined otherwise by a court or clinical process. So what does that mean for us? Those with cognitive impairments do not automatically forfeit their autonomy or decision-making capacity. Studies show that impaired individuals are still able to make some decisions for themselves. A clash can occur between the public, including family members, presumes that nursing homes are somehow able to control the residents that they serve and keep them from making harmful or, quote, bad decisions. We have the duty to honor individual wishes and value resident choices and control over their everyday lives. So what is our goal? The main point of this is we can't simply tell a resident they cannot do something. Our goal is to accommodate resident decisions. We want to lessen the severity of the risk, and then we want the resident to have the final say. So an example of this is instead of saying, I need to ask the nurse, respond with, okay, let me see what I can do. When we phrase it like that, it makes the feel like, when we say, let me ask the nurse, it takes away the decision and the power from the resident. We want to try and find alternatives that will make them happy. So what if it is a bad decision? Most people want to make their own decisions as long as possible, but when making decisions for others, they are often more concerned with safety and propriety than they are with autonomy. The question that is frequently raised, why do you let them eat the regular textured foods, refuse to turn, reposition, stay in bed, not participate in exercise. Given the noted emphasis on autonomy and rights, the more accurate question would be, what basis do we have to justify stopping them? While it might feel uncomfortable for staff and for families, individuals in nursing homes have the same right to make bad decisions as the rest of us do. We can only abridge their rights with appropriate assessment, care planning, and documentation. When residents make bad decisions that place them or the home at risk or against the advice of the clinicians caring for them, interdisciplinary team review is required. So what if their family thinks they can make decisions for them? We must educate our families, our residents' families, and DPOAs on our duty to resident rights. We can find common ground, and most families do want their person to be happy. We may need to schedule a care plan meeting to make sure everyone is aware of what the resident wants. Resident right trumps all. We want the resident to have the final say. So we want to ask ourselves, will the choice place the resident or others in immediate jeopardy or a life-threatening situation? So our first couple of examples are for people with diabetes. So scenario 1, Paul is a diabetic, but is not real strict with his diet. He's been asking for another piece of pie after having dessert already. What should we do? First, give them the pie, and then inform the nurse that they had seconds. This allows them to know that they need to monitor the resident and their blood sugars a little closer. Number 2, Tom is on hospice. He used to have strict diet orders. Now he is declining and he is needing more nutrition. He really likes orange sodas and ice cream. What should we do? We should give Tom all the ice cream and orange soda he wants and just let the nurse know. If this trend continues, nursing will want to notify the physician and update the care plan. As we're going through these examples, remember that these interventions will all be individualized based on each resident's needs as well as their circumstances. So here is another diabetic example. Number 3, Alvin is a brittle diabetic. He watches what he eats at meals. He seems to understand his disease. He also tries to get people to buy him candy bars. You can see him in his room sneaking a full-size candy bar. What should we do? Alvin is making a choice that could have negative consequences. Stop and talk with Alvin to make sure he understands the danger. Let the charge nurse know as soon as possible. Alvin will need to be watched carefully. So now we are going to kind of change topics to altered diets. So for example 1, Joy has just returned from the hospital. She's on speech therapy, but she's refusing her food to be ground. She wants a hamburger. What should we do? So we'll tell Joy that we'll see what I can do while informing the nurse of the resident's wants. The nurse will need to monitor the resident throughout the meal while they are eating the regular textured foods. The speech therapist will need to be contacted and the care plan will need to be updated with the resident wishes. So example 2, Jane is wanting to eat the cake served at the social with no milk added to it. What should we do? We'll ask Jane if we could steam the cake instead. If she's adamant on no moisture added, then let the nurse know and come up with an individualized solution. An example of that could be getting Jane a small piece of cake with supervision. Now we're going to switch to thickened liquids. Scenario 1, Harry does not want his liquids thickened. What should you do? Educate resident of the risk of not having thickened liquids. If he still refuses, inform the nurse that you are giving a drink without it being thickened, and he will need supervision throughout the drink, and the plan of care will need to be updated. Scenario 2, Marlene grabs another resident's drinks or will get water from the tap in the bathroom when staff is not around, despite being on nectar-thick liquids. What should we do? First, we'll ask Marlene if she would like a fresh drink. If appropriate, remind her in a respectful manner about why she is needing nectar-thick liquids. If she refuses and she still wants thin liquids, then give them to her and notify the nurse. We will need to update the plan of care and have an IDT meeting. So here's some examples on independence. So example 1, Sarah wants to walk to the library and the library is downtown, several blocks away. Sarah is independent in most ADLs in the home. Sarah remembers the frequent walks she used to take when she was younger and does not remember her limitations at this point in her life due to dementia. So what should we do? We're going to schedule a walk with Sarah. Tell her that you like to get out once in a while too. We want to make sure that we have someone on standby in case I need help. We're going to also monitor how far Sarah can walk. In this case, Sarah realized very quickly that she could not walk to the library and decided this was not a good idea. We then made sure she got home safely. Oops. So a resident is declining or refusing. So example 1, Glenn wants to skip breakfast. What should we do? Communicate to the other staff that he skipped breakfast so they can offer something to eat in a little bit. Notify the nurse so they can monitor intakes. And then we want to conduct a care plan meeting to discuss resident wishes if this is a continued pattern. Example 2, Donis often refuses to take her shower. So what should we do? We should see if she wants to take it later or if a different day would be better for her schedule. If she continues to refuse, ask her if there's something that you could do to improve her bathing experience. Ask her if there's a reason why she's hesitant to shower. Get the care plan team involved if refusals continue. We may need to change the bathing routine and approach. So we're responsible to educate residents of any potential consequences or health risks that may result from their decision. We are here to try to offer healthy alternatives. However, we are not to lecture them each time they make a risky decision. If a resident continues to want something different than what is in their orders or care plan, we need to be documenting these decisions. We want to make sure we're documenting discussions that we have with the resident and or their DPOA, alternatives you have offered, education that has been provided, and then update the care plan. Each decision we make as a home should be on an individual basis. We've said this a couple times already, but just because one thing may not be safe for one individual does not mean we have to keep another individual from doing it. Everyone is unique, and we have the same responsibility to find out what works for everyone. When you have questions, see your charge nurse or the neighborhood leader. We want our residents to have the last say. What can we do while providing the best care possible? Making our residents happy, that is our number one goal. Do not be afraid to ask questions when needed. So that was Melissa's presentation that they actively present in their home for trainings. So, a couple announcements. Please make sure that you notify our team with any updates if you have any changes in leadership in your home or you want to add someone to our communication. We just need their name, their email address, and what home they're with. We do not get notifications of any sort when there are changes in employment or position in homes. So please communicate those changes with us. Our next Lunch and Learn will be August 15th, and that will be on food committees and feedback. And then we will be reaching out to roll out our updated peak guidebook and outcomes. Our Person Senior Centered Care Conference will be on October 9th in Manhattan. Registration will be opening the beginning of September. We have 2 hotels in town that we've reserved blocks of rooms at. And those 2 are the Bluemont and the Holiday Inn on campus for those traveling long distances. More information will be coming via email. This conference is for anyone in this state. You do not have to be in peak. We provide CEUs if interested. If not, you do get a discounted rate. But yeah, it's open to everyone, and we have a lot of interesting topics that we're planning to present. If you have any questions, please reach out to us at coapeak@ksu.edu. Thank you.